manager for the Epilepsy Foundation of Colorado. I love this position. Afterwards, I will share my email in the comments, so feel free to reach out to me and email me if you have any questions about any of the programs that we have or just want to learn more information. Please stay on mute during the time that Dr. Collier is presenting and hold any questions till the end. You are free to put any questions you have in the chat. If you don't want to try to remember them, that's fine to just post them in there. So now time to introduce Dr. Collier. Dr. Collier earned her medical degree at the University of Texas Health Science Center at San Antonio. She then completed an internship, residency, and fellowship in clinical neurophysiology with a focus on epilepsy at the University of Utah. Dr. Collier completed an interprofessional fellowship in integrative medicine with the Academy of Integrative Health and Medicine. Dr. Collier has been the medical director of the epilepsy program at St. Mary's Hospital and Medical Group in Grand Junction since 2016. Her center has been designated since inception as a certified level 3 epilepsy center by the National Association of Epilepsy Centers, and is one of the few rural level 3 comprehensive epilepsy programs of its kind. She is a member and or fellow of the following organizations: the American Academy of Neurology, American Epilepsy Society, American Clinical Neurophysiology Society, American College of Nutrition, and the Academy of Integrative Health and Medicine. So without further ado, Dr. Collier.
Thank you so much, Larissa, and thank you everyone for joining us tonight. Can you hear me okay, Larissa? Am I okay?
You're good.
Okay, and Larissa, if there are questions at the end, if I try to look at the chat box, it comes up on my screen, which I'm sharing. So would you be able to maybe read any questions to me?
Yes, at the end, I will definitely read any questions we have.
Awesome, just field those for me. Great. All right, everyone, let's get started. So this is a topic that I'm fairly passionate about and have a lot of experience with. So it was pretty auspicious that the Epilepsy Foundation reached out to me and asked if I would be happy to facilitate this talk, which it is an honor to have this opportunity to share my experience, and I am passionate about it because I have seen patients get better with it. I've seen it change the trajectory of patients' lives as well as the lives of their family. But first, I'd like to give you a little bit more background. You had some of my background in the introduction there. I have been in Colorado since 2016, and I did help build a level 3 epilepsy center. I have a 4-bed epilepsy monitoring unit. During COVID, that has been a little bit of a challenge to keep open, so access to care has become more of a challenge for patients with epilepsy than I ever imagined. So that's been kind of frustrating, but at the same time, we are getting back on our feet. We've been designated since its inception as a level 3 epilepsy center. So what that means is patients with epilepsy are coming in, they're getting a comprehensive epilepsy workup. We do implant VNS at my hospital, and I'll talk a little bit more as we go take a deep dive into how that implantation process works. But we don't do resective surgery, such as epilepsy surgery, stereo EEG, or laser ablation. We also don't do responsive neurostimulation or DBS. But we are a comprehensive epilepsy center, and in doing so, we are able to help patients with epilepsy. In my experience with VNS as a fellow at the University of Utah, we did research with the Aspire, the 106 device, where it has a new feature that the older devices, the older generation devices didn't have, which it could sense and detect heart rate acceleration that occurs with focal seizures. And many times it could actually sense and stop and respond to the seizures before the patient even knew they were having an aura or anything along those lines. In fact, about 80% of the time, and the studies have shown that. So again, I'm kind of getting a little bit ahead of myself, but I do have a significant amount of clinical experience with the VNS. And Larissa, help me out here. Do I have 30 minutes to talk?
I think it's 45 minutes to an hour, and then we can work on it.
All right, cool. Well, I really and truly want to encourage people to, as I'm talking, if something is of interest and something you would like for me to expound on further, please type your question into the chat box. I think it's probably anonymous. I don't know. I'm not going to see who asked it anyway. And, I want you to feel comfortable to ask these questions. I want this to be a learning experience, even if there's something that's like, not even really related to VNS, but you feel like it's something that you would like to have answered. It's a burning question for an epileptologist. I'm happy to answer it. So I want this to be a valuable learning experience because you're taking time out of your evening to share it with us. And I want you to come away from it feeling enriched. So onward, if I can get this to advance. It was advancing a moment ago. So approximately 60,000 Coloradans are living with epilepsy. So epilepsy is the fourth most common neurologic disorder. It's actually more common than multiple sclerosis or Parkinson's disease, which tend to be talked about way more frequently and actually have more money dedicated to research through the National Institutes of Health. But epilepsy is a very, very common neurologic condition. And when patients are originally diagnosed, so I'm an adult epileptologist primarily, and when patients are diagnosed with epilepsy, they start out with some treatment goals, right? They want to stop seizures. They want medications with few or tolerable side effects that do not interact with other medications. They want to live a full and productive life and improve quality of life. I mean, these are things that really, if you were like looking at Maslow's goals or something along those lines, these are things that any human being would want, something that, satisfies your quality of life. Now, AED stands for anti-epileptic drug. And for the most part, most patients, when they're newly diagnosed with epilepsy, they are going to try using an anti-epileptic drug. That's usually what I do when a patient has a newly diagnosed seizure disorder, AKA epilepsy. Is they look at, I, as an epileptologist, am looking at seizure type, epilepsy syndrome, side effect profile, the patient's age, lifestyle, whether or not they're a female of childbearing age, that has some serious implications with certain medications in particular. Medication interactions, again, as an adult epileptologist, I'm seeing a lot of elderly patients with epilepsy. So I do have to take into account the other medications that they're taking. Also genetics, such as carbamazepine in people who are of Han Chinese descent, it can actually cause a fairly catastrophic rash. So it is something to keep in mind when I'm prescribing certain types of anti-epileptic medications. So that's usually the first step. If someone's getting to the point where they're needing a VNS, they've already kind of been through these steps, and I'll explain more about that in a moment. Unfortunately, medications have side effects. I call it the 7 dwarves that you wouldn't want to hang out with, like dopey, drowsy, grumpy, dizzy. And the reason why, and I almost liken it to chemotherapy, is seizures are powerful things, and it takes powerful drugs to stop them. And unfortunately, because you're acting at the central nervous system to kind of calm down hyperexcitable neurons, it doesn't just act on the neurons that are seizing, it acts on all of the neurons. The great news is for most patients, as they've been on the medication for a significant period of time, their body adjusts and it gets used to it. However, for some patients who are continuing to have seizures on their first medication, they're going to have a second, a third, sometimes I've seen fourth, fifth, sixth medication added. And the more medications that are added, the more side effects you're going to be experiencing. This is a little bit of an older chart, but it kind of gives you a sense of the history of anti-epileptic drug development. We're now in what I would call 3rd generation anti-epileptic medications. I have approximately 35 anti-epileptic medications to choose from, starting with bromide salts, which I have personally never prescribed, although I hear rumors that there are people still using this. I don't know where they're getting it, maybe the hot tub store, I'm not sure. But bromide salts was around the time of 1860. There was a story that they were looking at bromide salts versus saltpeter. They ended up using saltpeter as artillery in the Civil War and bromide salts in people with epilepsy. So we didn't get much further until 1918 when phenobarbital came out. And then shortly thereafter in 1930, phenytoin. And so as you can see, it's kind of escalated from there. And some of you might recognize some of these medications. The most common one that's most commonly prescribed now came out in around 1990-ish, levetiracetam, AKA Keppra. And this has gone on further. I want to add a new graph to this because we do have some newer generation anti-epileptic drugs. And the great news is, as we've advanced in our anti-epileptic drug therapy, we've gotten to where side effects are fewer, drug interactions are fewer, and tolerability is better. And unfortunately, the one thing we haven't gotten better at is effectiveness. So the thing that, and I'll show you a graph in just a moment. The thing that's interesting, and this is done in a study over the course of decades, the chance of seizure freedom with a medication, even though this line, as you can see, the trajectory has pretty much just gone up, the trajectory for getting better control of seizures has not really budged much at all, for the most part. There are some caveats to that. So factors that influence response to therapy: consistent use and adherence. Unfortunately, studies have shown that approximately 60% of patients with epilepsy will not take their medications as prescribed, because guess what? We're all human, and it's really hard to remember to take your medications twice a day. So studies do show if you miss your medication, that is one of the biggest risk factors for having a breakthrough seizure. Adequate dosage. So as patients grow, weight gain, weight loss, those types of things can influence dietary changes, other medications that are potentially interacting, that type of thing. So things that can affect your dosage. Using the right drug for the right type of epilepsy. So there are some seizure types that are actually exacerbated and worsened by certain seizure drugs. So that's something to be aware of. And then one of the biggest challenges I have as a neurologist and an epileptologist is having some patients who believe they have epilepsy, or who have events that look like epilepsy, but they might not actually be epileptic seizures. So this is a question just to kind of contemplate for a moment before I go into drug-resistant epilepsy and why we recommend neurostimulation devices. So what percentage of people with epilepsy will be resistant to medication, and kind of have a number in your mind as we go forward? It's a much higher number than I would have imagined. This is a much higher number than I like, because any number is too high for someone to have drug-resistant epilepsy. So the reality is that approximately between 35 and 36% of patients with epilepsy will be drug resistant. So this is called the Kwan and Brody study. And the numbers may vary just a little bit depending on which study you're looking at. But this was originally looked at in the 1980s or so. And then it's been, it's kind of like the shot heard around the world. The first time the study came out, people were like, no way. There's no way that this is real. And then they repeated the study and they repeated the study, and it's pretty much been fairly consistent, to the point where when I was an epilepsy fellow, or if you were to go and shake an epilepsy fellow awake in the 3 in the morning and say, what did the Kwan and Brody study show? You're like, 33% of patients with epilepsy will be drug resistant, or something like that. It's just like something that gets pounded into your head in residency and in fellowship, that you're going to have about 1/3 of your patients, which is not insignificant, who take medication are going to continue to have seizures despite being on their medication. And that can be very frustrating for the patient, very frustrating for the clinician, but it's not just frustrating, it's also dangerous, because when is a good time to have a seizure? Never, really, ever. And so, there's always going to be it's never a good time to, it's always going to be safer to have your seizure in your bed versus on a chairlift at a ski resort, of course. But at the same time, there's never a good time to have a seizure. And so you're looking at a population of people who are still going around with suboptimally managed seizures. So the International League Against Epilepsy, the ILAE, which is kind of, for me as an epileptologist, the governing body of my trade, if you will. They founded a long time ago, I think in the 1950s or so. And it was an organization, the ILAE, and they created some statements, and they're a very compassionate organization for and advocate for people with epilepsy. So the ILAE consensus definition is the failure of too appropriately chosen and too appropriately dosed anti-epileptic medications, whether one drug at a time or in combination to control seizures when used for an adequate period of time. And so again, if you've tried and failed 2 medications, essentially your chance of being seizure-free with yet the next medication is actually fairly negligible. And so that's why we had to start looking at other options to treat epilepsy. So again, just to hammer home, medically refractory or drug-resistant epilepsy is a trial of 2 medications, documented patient adherence. The patient is tolerating the medication, and yet they continue to have seizures despite being on their medication. So after failing 2 medications, there's less than a 5% chance that another medication will result in seizure freedom. And I know patients who have tried upwards of 9, 10, 15. I had one patient just yesterday, bless her heart, she said that she at one point was taking a handful, and I don't even get this, but she was taking 15 pills at a time every morning to help control her epilepsy, and God bless her for that. So this is conventional treatment options for epilepsy. So we have neurostimulation, brain surgery, diet, and medications. It probably should have been flipped the other way, right? It's like medications are typically going to be the first line drug, the first line therapy. And then after that, you've kind of got these other options. So neurostimulation devices is why we're here and what we're going to be talking about this evening. But brain surgery is always something that we keep in the back of our mind as epileptologists, as is this patient a candidate for epilepsy surgery? And that's based on a number of different things. Does your MRI show an area of the brain that has some scar tissue or some malformation or something to suggest that there's something we could go in and do surgical remediation of? Or does the EEG show a focality to it that is in an area of brain that is surgically resectable or a laser ablatable, that type of thing? For someone with primary generalized epilepsy, that of course is not going to be the case because you're basically having seizures all over your brain. Or if someone's having seizures in eloquent cortex, if you were to do surgery, they would never be able to speak again or something along those lines, then it's not, it's suboptimal. The ketogenic diet has come back in popularity in the 90s, much to the credit of the Charlie Foundation. Matthew's Friends is the Great Britain version of it. Interestingly, the ketogenic diet had been pioneered in 1910 by the Mayo Clinic. Give me just a moment here. It's been a long day of talking for this doctor, so bear with me. So 1910 is when the ketogenic diet was first pioneered by the Mayo Clinic, and then Johns Hopkins took it up until the 1930s. And if those of you who at this time of day were paying attention, remember that graph I showed you, what came out in 1930? Well, Dilantin. So why use a diet when you have a drug? So the ketogenic diet kind of got swept under the rug until the 1990s when Charlie Abrams and his family went to Hopkins and found a nurse who was willing to work with him to get his seizures under incredible control. And that's when the movie was made, First Do No Harm. Medications, as I said, we've already kind of hammered home medications. First line treatment, however, not without some types of detriment. And then back over here to neurostimulation, there's 3 FDA-approved neurostimulation devices currently: the VNS, which is vagal nerve stimulator, RNS, which is NeuroPace, and DBS, which is the deep brain stimulator. It is kind of the newest kid on the block, if you will, to the epilepsy arena. It's been used for quite a while for Parkinson's disease, and there have been promising studies showing that it can be effective for epilepsy. And so it is now FDA approved for that. That came out in, I believe, 2017. The VNS has been around for over 20 years, and NeuroPace was 2015. So the vagal nerve stimulator, so VNS, it is adjunctive treatment for epilepsy. It is also FDA approved for both depression and epilepsy. I call it deprelepsy. So for patients who have comorbid depression and epilepsy, they can get benefit from both. Greater than 100,000 patients have been treated using VNS therapy over the course of 20 years, and 33,000 of those are children. So it is delivered through a device. I've got one in my pocket right here. I grabbed it out of my office on my way home. So this is this is the Sentiva 1000, and it's a generator, and it's implanted on the left side of the chest. And they do that because on the right side, they found that it had more cardiac effects because the vagus nerve and this kind of schematic type of drawing that you see on the right-hand side of the screen, the vagus nerve is on both sides of the neck, and the vagus nerve has a lot of function. It's the longest cranial nerve in the body. It runs from the brain to the gut. And scientists found that if they stimulated the vagus nerve, that it had an effect on neurotransmitters. So it's delivered through a device with a generator and a lead. And you can see the generator with the lead there in the left-handed picture. And it controls seizures by sending mild pulses to the left vagus nerve in the neck at regular intervals all day, every day. So VNS therapy is used with seizure medications. It is programmed in the outpatient setting, typically a couple of weeks after implantation. And then it's followed by regular visits to have the VNS adjusted over time. And it may take several weeks or months to find the right settings. It's very, very customizable. And for myself as a trained clinical neurophysiologist, I like that because I like messing with things. I like customizing things. I like looking at engineered devices that can help people, and you can do things with them to make them customizable. That's the thing. If you've ever met someone with a VNS and they didn't like their settings, a lot of times it's something that hasn't been adjusted to customizable to their needs. So what I try to do when I have a patient with VNS, and it tends to be, I would say 95% of the time, incredibly well tolerated, so I listen to the patient and I hear what they're saying. And if they're like, I don't like this setting, we work really, really hard to make it very, very tolerable. Sometimes on very, very rare occasions that may not happen, but for the most part, most of my patients find the VNS to be very effective and very well tolerated. In fact, over time, they get so used to it that they can't even feel it anymore. So this is also a benefit. Medication doses may be lowered and the number of medications may be decreased. It's a very, very rare day. I have maybe a handful of patients that use the VNS as monotherapy, if you will, meaning that they don't actually take any medications. They use the VNS alone as their seizure control. It's not FDA approved, so that would be an off-label use for the medication. But at the same time, for some of my patients, they would prefer it that way. And so I respect that. I don't know why this is covering my screen now all of a sudden, but anyway, onward. It's also FDA approved for children. I don't know why this won't go away, so I apologize if this is covering up part of the screen. VNS therapy is proven safe and effective for children. So it's FDA approved for children as young as 4 years of age. That doesn't mean we can't use it off-label and implant it in children younger than that. That's just to say that that's what it's FDA approved for. As physicians, we get very used to and very comfortable using things off-label. It's also been FDA approved for focal epilepsy, meaning it was FDA approved for a certain seizure type. Does that mean we only use it for that seizure type? No. We are potentially using it off-label. Pediatric epileptologists have had to get very comfortable with using things in children off-label for a significant period of time, because up until recently, nearly every anti-epileptic medication for children was not FDA approved for children. And so they had to get used to prescribing things off-label. Hope that wasn't too confusing. But children with difficult to control seizures are treated with medicine alone may experience a decline in development. And that's definitely something that seizures are a setback. It's kind of like getting struck by lightning inside of your head. And every time you have a seizure, it's almost like having to pull yourself up out of a traumatic brain injury. And that doesn't help children learn. It's not conducive to learning. And so the more you seize in childhood, the more milestones and the more opportunities that you have to lose what you need to gain in the learning experience. So early use of VNS offers proven long-term outcomes for children at a critical time in their development. And then improvements in alertness, concentration, and energy have been reported in clinical studies. So I can't promise 100% seizure freedom. Do I see it? Absolutely. That's why I advocate for this device so heavily. But in the studies, that's not what the VNS showed per se. But what I can see and what I have seen and what I can promise more than anything, seizure freedom, it does happen, but I can promise decreased seizure frequency, decreased seizure severity, and improved recovery time. So let's take, for instance, the child who used to have a seizure before school. And then the child was like taken out for the rest of the day, had to miss school, the parents had to miss work. And so the child was missing school, missing opportunities to learn. The parent was missing work, missing opportunities to take care of the family and earn money to support the family. So what I've seen, especially in children, is you may still have a seizure, or your child may still have a seizure, but they're like, I still want to go to school, right? They're not taken out for the rest of the day. They have their seizure, they're awake, their postictal period is not as prolonged. They get on the bus and they go to school, and the parent is able to go to work. That's something I've seen over and over. And every pediatric epileptologist that I've met and I've worked with, they've seen that as well. It's pretty cool. So even if we don't see seizure freedom, we see things like that and improved quality of life. Why won't this go up? Oh, well, anyway, I'm sure one of you knows how to do it. I don't. Trying to advance my screen here. Okay, so again, we talked about the seizure frequency. Now this is really bothering me. All right, okay, let's go back. Okay, decreased seizure frequency, significantly reduced from baseline at each recorded interval. So what this graph shows is that I call it a potentiation effect. So what that means in English is just that it gets better and better and better and better. So you can see at 6 months, and that's usually what I tell patients, is don't really expect it to start being effective until it's been implanted for 6 months. And that's what the studies have shown. Does that mean that some patients can't start experiencing benefits immediately? No, because there are some people who do. There's the bell curve and there's outliers on either side of a bell curve of any sort. But usually what I say is give it about 6 months. And because everybody, the first thing they want to do as soon as they get the VNS implanted is start tapering medications, especially patients who are on like 5 medications. And I've had more than one situation where I've had patients on 5 medications and I've been able to get them down to 1 or 2 plus the VNS, and it's amazing. But I usually say, let's wait 6 months and then we'll begin tapering. And then you can see that you have a 36% improvement in seizure frequency, reduced at 6 months, 52% at 1 year, 58% at 2 years. The 5-year mark is really kind of the sweet spot, but when you see 60 to 65% at 6 years, and then 8 to 10 years, it's a 76% reduction in seizures from the baseline. So again, we don't really understand the true mechanism of action of the VNS. We know it works unequivocally. Studies have shown that over and over again. The American Academy of Neurology has at least 3 papers on the effectiveness of the VNS, but we don't really and truly know the true mechanism of action. The thought is that the VNS goes up, it stimulates the vagus nerve. From the vagus nerve, it goes to the brainstem, which is a very cranial nerve-rich area of the brain. From the brainstem, it goes up to the locus ceruleus. The locus ceruleus is a neurotransmitter-rich area of the brain, and what that's doing is it's releasing neurotransmitters that are believed to modulate seizures. So really and truly, at the end of the day, the VNS is the closest thing that we have to what I call disease-modifying therapy. And what that means is, so for multiple sclerosis per se, when I was a resident, I spent every night on call treating MS exacerbations. Like just everyone seemed to have MS exacerbations. And now the multiple sclerosis medications are so good, they're actually altering the trajectory of the disease state and actually disease modifying, so I call it DMT, disease modifying therapy. So patients actually aren't just mitigating symptoms, which is what anti-epileptic drugs do. They're actually improving their quality of life and altering the course of the disease. Unfortunately, in epilepsy, we don't have disease modifying therapy yet. And that's the holy grail, right? Like the day that we have disease modifying therapy for epilepsy is going to be, it's going to be like, hallelujah, you know, something that actually alters the course of this disease, as opposed to just mitigating symptoms, which is what seizure medications do. But the VNS, if you look at this graph here, what this graph shows to me is that in some respect or another, this is a neuromodulation device that is somehow disease-modifying therapy, which, I don't know, to me is exciting. All right, so quality of life improvements. Studies have shown that 80% of VNS users saw an improvement in overall quality of life. So for so many of my patients with epilepsy, seizures are actually the least of their problems. I know that sounds really strange to say, but it's something I've observed over and over and over again. There's problems with memory. That's a significant concern for patients with epilepsy. Academic achievements, verbal skills, mood, seizure clusters, post-ictal period, I talked about that, and alertness. And as you can see, as you go across here, each of these has an improvement at some level. So 38% improvement in memory, 39% academic achievements, until you get up to alertness, which is 63%. And some of that, there are many things that go into that, right? You're not having to be on so many medications, or you can be on lower doses of your medications. You're not having as many seizures. You're not taken out by the post-ictal state. And what I mean by post-ictal, so ictal is Latin for blow. So ictus is a blow. And so a blow can be anything. So you can consider a stroke an ictal event. You could consider a migraine an ictal event because it's a blow to the head. But in epilepsy, ictus, many of you have probably heard this word before if you've been in the epilepsy community for any time, or you've had to go see doctors, that type of thing. You've probably heard a doctor say, how long was your post-ictal period, or something along those lines. So post-ictal, ictus, post-blow to the head, post-seizure is how long it took for you after the seizure to recover, right? And for some people, they may not feel like themselves until the next day. Some people, it's a snap back. But what we've seen with the VNS is that the post-ictal period is not nearly as long or as severe. So much better post-ictal recovery. The time, so the seizure is the ictal event. After the seizure is the post-ictal event. And that time between here, you had a seizure, you have epilepsy, we know you're going to have another one at some point in your life. That time between them is called the interictal period. And my goal for patients with epilepsy is to make that interictal period forever. Like, you know, like you never have another seizure. That's my goal, but that's the interictal period. All right, so the other thing, I don't know if I've got another slide, but I'm going to talk about this first. So the VNS has 3 settings. So the first one is normal mode. It's on and it's off, and it's on and it's off, and that's called the duty cycle. And the duty cycle is how much of the time during the day the VNS is going off. When you originally program the VNS, it's going to be usually around 5 minutes. It'll go off for every 30 seconds. So that's the normal mode. The newer devices also have something called auto stimulation, and that's what I had mentioned at the beginning of my talk, was the automatic sensing and responding to that ictal tachycardia, there's the word ictal again, that acceleration in heart rate that happens with a seizure. It's very different than the acceleration that heart rate that happens if you start jogging or going upstairs, unless you're Usain Bolt or something like that. For most people, when they exercise, it's going to be a gradual raise in their heart rate versus a spike. So that's the auto stimulation, and that can sense a seizure and respond to it. And then there's the magnet, and my patients and their family members love having the magnet. And it's like a little wristband, and you can put it on the VNS. You hold it there for approximately 2 to 3 seconds, and it will automatically send an extra higher amplitude pulse of therapy to the device, and it can potentially abort the seizure, and it can decrease the severity of the seizure. For some of my patients, if they can feel an aura coming on and they catch it in time, they can actually affect the seizure themselves, or family members can go up and they can swipe the magnet when someone's having a seizure, and it can improve the post-ictal period. So that is another little tool. And so that's another thing about the VNS for a lot of my patients. When a patient has epilepsy, they're always just kind of waiting for the other shoe to drop, meaning that they never know when they're going to have their next seizure. And that can be very scary. That can make public situations very challenging, because again, as I said, there's never a good time to have a seizure. And so if you're in the store, and I'll tell you, Walmart is a seizure trigger as far as I can tell. Nothing is Walmart, well, anyway. maybe something against Walmart, but let's not go there. The bright lights, the reflective surfaces, the loud noise, something about it is like a seizure trigger for my patients. So I'm like, order online if you have to do something there. Just order online, because I've had so many patients have seizures in Walmart, and it's a terrible place to have seizures. It's like hard floors and unforgiving surfaces. But if they know they're about to go to Walmart, I don't mean to use that as an example, I'm not harping on Walmart, just stores in general that with bright fluorescent lights and reflective surfaces and loud people and a lot of stimulation. You can actually swipe the magnet before you go in and kind of like preemptively, like give yourself a little vagus nerve stimulation so that you may not actually have a seizure while you're trying to shop. The other option, as I said, is just order online and pick up. Anyway, most side effects associated with VNS therapy occur during stimulation. This is what you experience: hoarseness, cough, paresthesias, shortness of breath. It may occur during stimulation and generally diminishes over time. I'll tell you the truth. I have had some patients say to me that they miss it and they liked having that feedback that they could feel, because it helped remind them that they had something, right? My favorite day is actually the day we turn on VNS for my patients. It's such a great day. They come in, they're like anxious. They don't know how it's going to feel. They've like created all these things in their head about like what it's going to be like. They like come in, they sit down, I give them a wand. I'll show you a picture of the wand in a second. And I've got the tablet and I'm like, are you ready? And they're like, ready. And we turn it on and they're like, oh, that was it. And they're like totally surprised, because it was not anything like they expected. I have patients that say it like it feels like a slight pulling or a puff of air, or one patient said bubbles. Some patients will start giggling. But I'll tell you, especially for patients who've been struggling with epilepsy that hasn't gone anywhere for upwards of 2 decades, and that's what the studies show, that most patients with epilepsy don't actually get to see an epileptologist or start having a comprehensive epilepsy workup for upwards on average between 15 to 20 years. So the VNS becomes this validation that somebody's doing something, somebody finally listened, and somebody isn't just going to throw another drug at you and say, try this one and see if it works, right? That just makes people have hope, and that there's something out there besides, here, try this drug. It may or may not work for you, right? And again, if you've already tried 2, it's not going to. So let's like move on, right? That's the way I look at it. Anyway, that's me. So you can see 1 year, 2 years, 3 years, it diminishes over time. So you've got the hoarseness, 25%. I have some patients call it their Batman voice or the fan voice, you know, when you're like talking to a fan when you're a little kid. I don't know if you guys did that, but I did for some reason. It's like a kid thing to do. Maybe I should like start doing it again because it was very satisfying. I just don't get around box fans very much, but they were everywhere when I was growing up. But it's like a fan voice, and it's like, and it does diminish over time. And the cool part too, for those of you who are absolutely dying to do karaoke or have spoken word or open mic night or whatever, you can take the VNS, the VNS magnet and tape it with not duct tape, but like, you know, some medical tape that's like gentle on your skin. You can tape it to the VNS. And if it's taped over the device for 60 seconds, it actually shuts the VNS off. And then when you remove it, the VNS comes back on and starts working. So I had one patient, he like taught Bible study, and he found these shirts with these cute little pockets. And he would actually drop his magnet in this little pocket right here while he was teaching Bible study. And then he would like take it out at the end of Bible study class, and he just didn't want it going off then. But guess what? Like, he doesn't even have to use that now because he's had it in for 3 years and it doesn't go off like that anymore. So you do get used to it over time. And then cough, paresthesia, shortness of breath. And yeah, hoarseness is the main one, voice change. And especially in the time of COVID, a lot of my patients have gotten really self-conscious about having a hoarse voice, you know, because everybody's a little bit on edge for obvious reasons. And so they get self-conscious about having a hoarse voice. And again, it's very customizable, and that can be mitigated with settings. So this was the one that I had an opportunity to do research on when I was a fellow. This was the very first one that had a closed loop system where it could actually sense and respond to an acceleration in heart rate called the auto stimulation. It detected the rapid heart rate rise. Again, that spike delivered an automatic stimulation, had customizable parameters, and it worked with the magnet, but it worked better than the magnet because it was like a built-in magnet, and it could actually sense the seizure before a patient knew they were having it. This is up here in this top corner, what it looks like. This is the Th1nk26. That's the same one I just showed you. And then the magnet, the wand is right there next to the tablet. And when I was a fellow, we had a Palm Pilot. Some of you probably have never seen one of those, consider yourself fortunate, but it was kind of like the first BlackBerry kind of thing. But it was like super cumbersome. There were cables, but I had gotten used to it. And it was like, I became this like whiz with this like BlackBerry looking thing and this stylus. And, when the therapeutic consultant, the rep who worked with me showed up to take my Palm Pilot away, I was like, this is my security blanket. What are you doing to me? What have you done? And they gave me this iPad essentially and a wand. And I was like, what is this? And now I actually love it, and it works great. And it's got this beautiful, very user-friendly interface, because guess what? The engineers came to doctors and asked us what we wanted and asked us what we needed. And surprisingly, they listened to us, the only people who ever have listened to a doctor probably, and gave us what we wanted. And it's great because it helps patients. It's very user-friendly. It's elegant. It's wonderful. It's fun when I'm standing in the elevator at the hospital. And actually, it's a conversation starter because it's kind of cute, and people will ask me about it. But the patients show up and I start programming with this tablet here. All right, I should hustle here. So yeah, smallest device, customizable wireless wand, Bluetooth, done. All right, the Th1nk26 was really cool because it had day-night programming and it has scheduled programming. For myself, who has lived in the Rocky Mountain West since 2009, I did medical school in Texas, so I didn't have to worry about snowstorms and mountain passes. But when I moved to Utah, then Montana, and now Colorado, having patients come in the wintertime over mountain passes is suboptimal. So there's scheduled programming where you can actually set it up so patients don't have to keep coming in for appointments. It can do automatic settings, which is amazing. And then there's day and night programming, which you can use for patients who have either daytime seizures or nighttime seizures only. And that's a very, very nice feature. So this is the auto stimulation. So this is a typical seizure progression right here. This is a focal seizure. This is an EEG, an electroencephalogram. It is the tool that we use as epileptologists to capture seizures. It's a perfect focal seizure here that's captured. And then on this next page, you can see the auto stimulation here. And you can see basically the seizure starts here. And then the heart rate, this is the EKG right here, the echocardiogram or the electrocardiogram. This is the EEG. We always have an electrocardiogram strip running down here for various reasons that I won't go into today. But then the heart rate becomes fast, tachycardia. It's detected. It goes from 80 beats per minute to 96 beats per minute. The automatic stimulation is delivered and the seizure stops. Boom. So over 60% of seizures treated ended during automatic stimulation, which is really, really cool. All right. So that being said, and I'm so sorry, this is like blocked. There is information. Knowledge is power. And that's why you are here this evening. And I really appreciate you being here. You can take a deep dive and go on to vnstherapy.com. It is a bounty of information. There's videos from patient ambassadors, patient stories, more information on how it works if you weren't able to get enough here. You can actually connect with one-on-one with ambassadors. There's a VNS therapy community chat, which I do on the third Thursday sometimes, kind of sporadically. I haven't figured out what kind of schedule they have me on. I think the next time I do it is in August, but it'll be the third Thursday or the first Tuesday. And it's actually like a webinar. And so you can watch it. There's also staff, there's nurse case managers, clinical specialists, and therapeutic consultants, which are my boots on the ground who help me. They're like indispensable, and they're amazing human beings. They will help you on so many levels. It's pretty amazing. They're dedicated to this cause. There's webinars here. I did the one. It's also under patient resources. I did the one, Women and Seizures, the Unique Challenges. I think I might have been hoarse that day, but you can. It's still pretty decent talk, if I do say so myself. So also, of course, this is from the Epilepsy Foundation. There is the Epilepsy Foundation website where you can go on and get more information. And this is the same image I had showed you earlier with the Sentiva, the magic wand, and the tablet that replaced the BlackBerry Palm Pilot thing. And it was a change that was for the better, even if I didn't want it at first. And down here, you can kind of see the link to it, but really, if you just go on epilepsy.com and type in the search engine, vagal nerve stimulator, it will come up.